Pharmacology is the branch of biological science that studies drugs. It concerns itself with the origin of drugs, their physical and chemical properties, the ways they act within the body, their mechanisms, side effects, and toxicities, as well as the methods of administration, dosage, and the processes of absorption, distribution, metabolism, and excretion. In short, it provides the basic therapeutic knowledge needed for medicine and examines how drugs are applied in clinical practice. Within pharmacology, several subfields are recognized. Pharmacokinetics investigates the journey of a drug through the body, focusing on absorption, distribution, metabolism, and elimination. Pharmacodynamics explores how the chemical structure of a drug relates to its biological activity, examining the dose-response relationship and the mechanisms of drug action. Pharmacotherapeutics studies the use of drugs for prevention, diagnosis, and treatment of disease, while clinical pharmacology looks specifically at how the human body responds pharmacologically to drugs in medical practice. Toxicology, on the other hand, emphasizes the harmful effects of drugs and other chemicals, including overdoses and environmental exposures, not only in individual organisms, but also in ecosystems. A drug is broadly defined as any compound with the capacity to produce a biological response, whether that is a physiological, biochemical, or structural change. In everyday medical practice, however, the term drug often refers more specifically to those substances whose biological activity has proven useful in the diagnosis, treatment, or prevention of disease. In this narrower sense, drugs are synonymous with medicines. Drugs may be classified in several different ways. One common system is by purpose of use. Some drugs are employed for prevention, creating artificial immunity and enhancing resistance to disease, as is the case with vaccines and toxoids. Others are used for treatment. Within this therapeutic category, there are drugs aimed at eliminating the underlying cause of disease, an approach called causal or etiological therapy, such as antibiotics in chemotherapy. Alongside this are drugs used primarily for symptom relief. These do not eradicate the root cause, but reduce discomfort and suffering. Painkillers and anti-inflammatory drugs are among the most widely used, and in practical terms, symptomatic therapy occupies a large place in clinical medicine. Another method of classification is by source. Crude drugs are obtained from natural materials, animal, plant, or mineral, through simple processes like drying, extraction, or grinding. Cod liver oil, deer antler, and musk are examples of animal-derived crude drugs. Opium, licorice, ginseng, and digitalis leaves represent plant sources, while alum, gypsum, and talc illustrate mineral sources. From these crude substances, chemists may extract active components or synthesize entirely new compounds. These are referred to as chemical preparations. Morphine from opium, cocaine from coca leaves, insulin from the pancreas, and heparin as an anticoagulant are naturally derived examples, while aspirin, para-aminosalicylic acid, and barbiturates are synthetic. From both crude and chemical origins, drugs may then be processed further into pharmaceutical preparations suitable for therapeutic use, such as tablets, capsules, tinctures, or ointments. Finally, drugs can also be classified legally under pharmaceutical law. Common drugs are those considered safe for general use. Poisons and powerful drugs, by contrast, have doses that approach toxic or even lethal ranges, or have such strong effects that careful regulation is required. Psychotropic drugs act on the central nervous system and pose risks of habit formation or abuse. Narcotics, including alkaloids extracted from the poppy, opium, or coca leaves, as well as their synthetic derivatives, are strictly controlled because of their potential to create both physical and psychological dependence. Pharmacology, therefore, is not simply a catalog of drugs, but a comprehensive discipline that links chemistry to biology, mechanism to therapy, and laboratory science to clinical practice. It asks how a drug moves through the body, how it acts, what benefits it offers, what dangers it poses, and how best it can be used to preserve health and treat disease. Pharmacological action refers to the changes in physiological functions that occur when a drug is administered to a living organism. These changes arise from the chemical or physical affinity between the drug and the body's tissues. In essence, when physiological functions deviate from their normal state, drugs act to restore equilibrium, thereby helping to maintain homeostasis. The ways in which drugs act can be understood in several dimensions. At times, they stimulate bodily functions, enhancing or accelerating normal activity, while at other times they depress or suppress activity. For example, digitalis strengthens the heartbeat and promotes diuresis, while caffeine or amphetamines stimulate the central nervous system. By contrast, morphine reduces pain through depression of nervous activity, and adrenergic blockers slow the heart by suppressing sympathetic function. Drugs may also act directly or indirectly. A direct or primary action occurs when the drug exerts its effect directly on the tissue or organ. Digitalis, for instance, produces a direct cardiotonic effect by acting on the heart muscle itself. Indirect or secondary action, however, occurs when the drug influences another system first, producing a secondary consequence elsewhere. Again, with digitalis, the improved cardiac function leads to better renal circulation, and this secondary effect manifests as diuresis. In some cases, drug effects remain confined to the site of administration, producing a local action. Local anesthetics applied to the skin or eye drops instilled into the conjunctiva are good examples. Other times, the drug enters the bloodstream, distributes widely, and exerts systemic effects across multiple tissues and organs. We may also distinguish between general and selective actions. A general action spreads broadly across tissues, while a selective action targets specific organs or structures. This concept explains why certain drugs act almost exclusively on one system, while others affect many at once. Every drug has both a principal or intended therapeutic action and potentially secondary or unwanted effects. The main action is the beneficial one for which the drug is prescribed, while side effects or adverse reactions may range from minor inconveniences to serious harmful outcomes that interfere with therapy. The mechanisms behind these actions vary. Some are simple, such as the neutralization of gastric acid by antacids or the osmotic action of laxatives. Others involve inhibition of enzymes, such as acetylzolamide's suppression of carbonic anhydrase. Yet the majority of pharmacological actions are explained by receptor theory, first proposed in the early 20th century by Paul Ehrlich and J. N. Langley. Receptors are specific protein molecules usually embedded within the lipid bilayer of cell membranes where drugs can bind and trigger a cascade of biochemical responses. The strength of binding between a drug and its receptor is called affinity, and the higher the affinity, the more potent the drug's action tends to be. Drugs that bind to receptors and mimic the natural action of the body are called agonists. A full agonist produces the maximal possible response at the receptor, while a partial agonist produces a lesser response, even if all receptors are occupied. Interestingly, partial agonists can act as partial antagonists when given alongside full agonists because they reduce the maximum effect that the full agonist could otherwise achieve. Antagonists, on the other hand, bind to receptors without activating them. Instead, they block agonists from binding and prevent the receptor from exerting its natural action. A competitive antagonist binds reversibly to the same receptor as the agonist, so that increasing the concentration of agonist can overcome the block and restore the full effect. A non-competitive antagonist, however, binds irreversibly or at a different site, altering the receptor in such a way that even high levels of agonist cannot restore full activity. In this case, the maximum achievable response is lowered. The chemical structure of a drug is intimately tied to its pharmacological action. A drug binds to a receptor only if its structure is complementary to the binding site. Any change in chemical structure can alter not only the drug's physical and chemical properties, but also the type of receptor it binds to, the strength of its affinity, and the interactions it produces. This explains why morphine, a powerful central nervous system depressant, can be chemically modified by the removal of a single water molecule to produce apomorphine, a drug that instead excites the vomiting center and produces stimulation rather than depression. Such relationships between chemical structure and biological activity, what pharmacologists call structure-activity relationships, remain one of the central concerns of modern pharmacology. In this way, pharmacological action can be seen not simply as the effect of a drug, but as the outcome of a precise interaction between chemistry and biology, one that depends on the nature of receptors, the affinity of binding, and the subtle variations of molecular structure that can transform a depressant into a stimulant or a therapeutic into a poison. When we talk about pharmacological action, it is important to understand that a drug never acts in isolation. Its effects on the body are strongly influenced by a variety of factors. The first and most fundamental factor is dose. A drug must reach a minimal effective dose in order to produce any observable action. This is the lowest amount necessary to trigger a pharmacological response. Between this minimal effective dose and the maximal effective dose lies what we call the therapeutic dose, which is the amount usually prescribed in clinical practice. For adults, this is often referred to as the standard dose. If the dose rises too high, it reaches the toxic dose, the point at which harmful or poisoning effects appear. There is also what we call the tolerated dose, a level that produces intoxication but can still be endured without immediate death. Beyond this lies the lethal dose, the amount that causes death, often measured as LD50 in animal experiments. The second factor is age. Standard doses are typically calculated for healthy adult men between the ages of 20 and 60. Infants, children, and the elderly respond very differently. Their sensitivity is higher because the organs responsible for metabolism and excretion are either immature or weakened. In infants, the blood-brain barrier is not fully developed, which allows drugs to act more strongly. For this reason, pediatric doses must be carefully adjusted using formulas such as Young's rule, Clark's rule, or Augsburger's formula, which take into account the child's age, body weight, or body surface area. For example, Young's formula calculates a child's dose as age divided by age plus 12, multiplied by the adult dose. The third factor is sex. Women are often more sensitive to drugs than men. Their smaller body size means that the same dose can be relatively larger, and the higher proportion of body fat increases absorption. Sex hormones also play a role in metabolism. During pregnancy, drug administration requires special caution because of possible effects on the fetus, and during breastfeeding, one must also consider the transfer of drugs into breast milk. The fourth factor is constitution, or individual predisposition. Some people show unusual or abnormal reactions to drugs. This is called drug idiosyncrasy, often due to genetic defects in metabolism. Another situation is drug hypersensitivity, or drug allergy, which arises when the body produces antibodies against a drug molecule seen as an antigen. On repeated exposure, the drug-antibody interaction can trigger allergic reactions, ranging from mild skin rash to severe anaphylaxis. A fifth factor is the effect of repeated use. When drugs are given repeatedly, three important phenomena may occur. One is tolerance, in which sensitivity decreases over time and higher doses are required to achieve the same effect. Another is accumulation, which happens when absorption exceeds metabolism and excretion, causing the drug to build up in the body and produce toxicity. A third is drug dependence, where the body or mind develops a compulsion to continue using the drug. Dependence can be psychological, meaning the person strongly craves the drug when it is withdrawn, as in smoking. Or it can be physical, where withdrawal causes clear symptoms, as in addiction to narcotics. The sixth factor is the combined use of drugs. When two or more drugs are taken together, they may reinforce or weaken each other's actions. If the total effect is equal to the simple sum of each drug's effect, we call it additive action. If the combined effect is much greater than the sum, it is called potentiation or synergism. But sometimes drugs work against each other. This is called antagonism, where one drug reduces or cancels the action of another. Finally, we must not forget the placebo effect. Even when a pill has no active ingredient, if the patient believes it is a real medicine, their symptoms can improve. This effect is purely psychological, yet it demonstrates the powerful influence of expectation and belief on the therapeutic process. So, as you can see, pharmacological action is never determined by the drug alone. It is shaped by dose, age, sex, individual constitution, repeated use, drug combinations, and even the patient's own mind. Understanding these factors is essential for safe and effective drug therapy. Pharmacokinetics is the study of what the body does to a drug. In other words, it describes the dynamic journey of a drug once it enters the body. The key processes are summarized by 4 terms: absorption, distribution, metabolism, and elimination. These 4 together determine how much of a drug reaches its site of action, how long it stays there, and how it is finally cleared from the body. Let us begin with absorption. This refers to the process by which a drug crosses cell membranes and enters the bloodstream. The structure of the cell membrane is crucial here. It is built as a bilayer of lipids, mainly phospholipids, with proteins embedded inside. Because of this, lipid-soluble substances can easily cross the membrane by simple diffusion. Water and very small non-lipid particles can pass through tiny pores, while glucose and amino acids require specialized carrier systems. If a molecule is large and water-soluble without a carrier, absorption becomes very difficult. Another important factor in absorption is the relationship between the drug's ionization and pH. Most drugs are either weak acids or weak bases, and they exist in both ionized and non-ionized forms depending on the surrounding pH. The ionized form is poorly lipid-soluble, while the non-ionized form crosses membranes much more easily. For weakly acidic drugs, absorption improves in acidic environments where ionization is low. For weakly basic drugs, absorption is better in alkaline environments. This is why stomach acid, with its low pH of 1 to 3, favors the absorption of acidic drugs, while the small intestine, with a pH closer to 8, favors the absorption of basic drugs. We also speak of bioavailability, or BA. This refers to the proportion of an administered drug that reaches the systemic circulation in its unchanged form. Bioavailability is usually discussed in the context of oral administration, since a pill must survive stomach acid, digestive enzymes, and the so-called first-pass metabolism in the liver before it can reach the blood. Many factors influence bioavailability, including the chemical structure of the drug, the formulation of the dosage form, the route of administration, and the stability of the drug within the gastrointestinal tract. Once absorbed, the next process is distribution. A drug that enters the bloodstream does not remain evenly spread. Instead, it may bind to plasma proteins, such as albumin for acidic drugs or alpha-1 acid glycoprotein for basic drugs. When a drug is bound to plasma proteins, it is inactive. It cannot cross capillaries, it is not filtered by the kidney, and it is not metabolized. It acts almost like a reservoir, storing the drug in an inactive form. Only the unbound or free fraction of the drug is active. Because protein binding is reversible, drugs can compete for the same binding sites. If 2 drugs with similar binding preferences are given together, one may displace the other, increasing the concentration of the free, active form and suddenly intensifying its effect. This is why careful attention is needed when combining medications. Drugs can also bind to tissues. Some have a strong affinity for specific organs. For example, iodine accumulates in the thyroid gland, and heavy metals such as lead tend to concentrate in bone. This selective distribution means that certain drugs, although present throughout the body, show strong effects in particular organs. Digitalis, for instance, circulates widely, but its principal action is on the heart. An important protective mechanism of the body is the blood-brain barrier. In the central nervous system, capillaries are tightly sealed by endothelial cells and glial support, preventing most substances from passing through. Only small, lipid-soluble molecules or nutrients essential to brain function can cross. Large, water-soluble molecules are excluded. In a similar way, the placental barrier restricts the passage of drugs from the mother to the fetus. Here again, lipid-soluble and non-ionized molecules pass more easily, while large ionized molecules do not. Because some drugs can cross the placenta and affect the fetus, drug use during pregnancy must always be considered with great caution. After a drug is absorbed and distributed, it does not simply stay in its active form forever. It usually undergoes metabolism, also called biotransformation. This is the process by which the body chemically alters a drug, and it is one of the key factors that determines how long the drug's action will last. The liver is the central organ for drug metabolism, particularly through the enzyme systems located in the microsomes of liver cells. However, metabolism can also occur in the intestinal mucosa, in the blood, in muscle tissue, and in the kidney. Most drugs are converted into more polar, water-soluble substances that are easier to excrete. Sometimes, however, the metabolite itself is active. In fact, some drugs are deliberately designed as prodrugs. These are given in an inactive form and only become active after they are metabolized inside the body. Drug metabolism is often divided into phase 1 and phase 2 reactions. They usually happen in sequence, but not always. Some drugs may undergo only one phase, and sometimes phase 2 can even occur first. Phase 1 reactions are degradation reactions. They introduce or expose functional groups on the drug molecule through processes such as oxidation, reduction, or hydrolysis. The cytochrome P450 enzyme system in the liver is especially important for oxidation. These enzymes use molecular oxygen and reduced NADP, NADPH to carry out the reactions. For example, nitro and azo groups can be reduced, and ester compounds may undergo hydrolysis. It is worth remembering that not every drug is metabolized. Some are excreted unchanged. Phase 2 reactions are conjugation reactions. Here, the drug or its phase 1 metabolite combines with an endogenous substance, such as glucuronic acid, sulfuric acid, or an amino acid. This conjugation neutralizes the drug's activity, makes it more water-soluble, and prepares it for excretion. Unlike phase 1, conjugation requires energy. Once metabolism has occurred, the body must remove the drug. This process is called excretion. The kidney is the most important organ for drug elimination, but the gastrointestinal tract, the lungs, the skin, the salivary glands, the mammary glands, and even the placenta may all play a role. Let us first consider the kidney. Drugs are cleared from the blood by 3 mechanisms: glomerular filtration, tubular secretion, and tubular reabsorption. Water-soluble, unbound drugs are filtered easily by the glomeruli and then pass into the urine. Lipid-soluble drugs, on the other hand, tend to diffuse back through the tubular epithelium and are reabsorbed into the blood. This is why metabolism in the liver, which transforms lipid-soluble drugs into water-soluble metabolites, is so important for excretion. The pH of urine also influences drug elimination. Acidic drugs are excreted more rapidly in alkaline urine, and basic drugs are eliminated faster in acidic urine because ionization reduces reabsorption. Excretion can also take place through the gastrointestinal tract. Some drugs are secreted in saliva, some are released directly into the stomach or intestine, and others enter the bile. An interesting phenomenon here is enterohepatic circulation. In this process, a drug is metabolized by the liver and secreted into bile, then released into the intestine. From there, part of it is reabsorbed into the bloodstream and carried back to the liver, where the cycle repeats. This can significantly prolong the drug's presence in the body. Other routes of excretion include the lungs, which eliminate volatile substances such as alcohol and anesthetic gases, the mammary glands, which can pass drugs into breast milk, and the skin, which excretes certain substances in sweat. When we talk about drug administration, we are simply asking, how do we get the drug into the body? There are several different ways, and each has its own advantages and disadvantages. The most natural way is oral administration, or taking the drug by mouth. It is convenient, safe, inexpensive, and suitable for large doses. Most absorption happens in the small intestine, but some drugs can be absorbed in the stomach. There are even medications, such as certain laxatives, that are not absorbed at all, but act directly within the digestive tract. However, oral administration has its drawbacks. The presence of food in the stomach can slow or reduce absorption. Stomach acids and digestive enzymes may inactivate some drugs. Drugs that undergo extensive first-pass metabolism in the liver have low bioavailability, meaning only a small portion reaches the bloodstream. And of course, oral medication cannot be used in patients who are vomiting, have difficulty swallowing, or need immediate effects. Another important category is parenteral administration, meaning any route that bypasses the digestive system. The most common is injection. Injections are used when oral intake is not possible or when rapid onset of action is required. Because the drug enters directly into circulation, it avoids the stomach, intestines, and first-pass liver metabolism. However, injections are more expensive, require sterile technique, and once given, the dose cannot be removed, so side effects may be more dangerous. Within injections, there are several types. Intradermal injection is given just under the skin surface, for example in allergy testing or tuberculosis screening. Subcutaneous injection, given into the fat layer under the skin, allows slower absorption than oral intake, but faster than topical application. Insulin and some vaccines are given this way. Intramuscular injection goes into a muscle, where blood supply is richer, so absorption is quicker. Irritating drugs can also be given here with less pain, and oily solutions or suspensions can be absorbed slowly for prolonged action. Intravenous injection delivers the drug directly into a vein, giving the fastest and most precise effect. It allows immediate action and accurate blood concentration, but also carries higher risk, since adverse effects appear quickly and cannot be reversed. Intra-arterial injection is less common and used when we want a high concentration of a drug to act locally, such as in cancer chemotherapy or radiologic procedures. Finally, intrathecal injection into the spinal canal is used to anesthetize nerves for surgery in the lower body. A second parenteral method is inhalation. Gaseous or volatile drugs can be absorbed rapidly through the large surface area of the alveoli in the lungs. Even non-volatile drugs can be inhaled if converted into aerosols. This route provides rapid action, especially for anesthetics or asthma medication, but the dosage can be difficult to control and the lung tissue may be irritated. Drugs can also be administered rectally. This is useful for unconscious patients, those who are vomiting, or small children. Suppositories or liquid preparations can be absorbed through the rectal mucosa. Anticonvulsants and antipyretics are common examples. There are also oral mucosal routes. A sublingual tablet placed under the tongue is absorbed very quickly, bypassing the liver and entering the bloodstream directly. Nitroglycerin for angina is a classic example. A buccal tablet placed in the cheek dissolves slowly, providing sustained release of the drug. Hormone preparations are often given this way. Finally, there are topical or external applications. These include ointments, creams, lotions, eye drops, nasal drops, and others, mainly for local action. However, newer transdermal systems, like nicotine or estrogen patches, allow drugs to be absorbed steadily through the skin into the systemic circulation, providing continuous effects without injections. When we speak of side effects, we are referring to any unintended effects of a drug that occur at doses normally used in medical practice. Among these, the most important category is adverse drug reactions. These are harmful and undesirable responses that happen even when a drug is taken at standard therapeutic doses. Some adverse reactions manifest as blood disorders. Certain drugs can suppress bone marrow, leading to anemia, a drop in white blood cells, or a reduction in platelets. This is often seen with anti-cancer drugs that inhibit cell proliferation. Other drugs can cause hemolysis, the destruction of red blood cells, particularly in patients who carry certain genetic deficiencies. The digestive system is another frequent target. Pain relievers, anti-inflammatory drugs, and corticosteroid hormones may all damage the lining of the gastrointestinal tract. They reduce the stomach's natural defenses and delay healing, which can result in gastrointestinal bleeding. The liver can also be affected, often leading to jaundice. In some cases, this is due to direct injury to the liver cells themselves, known as hepatocellular jaundice. In other cases, the bile ducts become obstructed, preventing bile from being excreted, which produces obstructive jaundice. The kidneys are vulnerable as well. Certain drugs, or their metabolic byproducts, are poorly soluble in urine. When they crystallize within the tubules, they block urine flow and cause injury. Toxic heavy metals, such as mercury, directly damage the tubular epithelial cells, sometimes leading to complete suppression of urine output, or anuria. Side effects can also occur when multiple drugs are combined. Antibiotics may alter the intestinal flora, decreasing the production of vitamin K, which in turn enhances the anticoagulant effect of drugs like coumarin and increases the risk of bleeding. Drugs that compete for the same protein-binding sites in the blood, such as bishydroxycoumarin and tolbutamide, can displace each other, leading to severe hypoglycemic attacks. Monoamine oxidase inhibitors, when combined with foods rich in tyramine, prevent its breakdown and can trigger dangerous spikes in blood pressure. Neuromuscular blocking agents like curare may cause respiratory paralysis when combined with certain antibiotics. Finally, thiazide diuretics often reduce blood potassium, which makes it easier for digitalis, a cardiac glycoside, to trigger arrhythmias. In summary, side effects range from mild to life-threatening and may involve blood, the digestive tract, the liver, the kidneys, or result from drug interactions. This is why careful monitoring, knowledge of drug combinations, and individual patient differences are all critical in pharmacology. When we talk about the development of a new drug, we are describing a long and complex process, beginning with laboratory discovery and moving step by step through animal studies, human trials, and finally, post-marketing surveillance. Before a drug is ever tested in humans, it must first undergo non-clinical studies. These are performed in animals, never in people, and their purpose is to evaluate pharmacological activity and potential toxicity. They are sometimes called preclinical studies. Non-clinical pharmacology examines the drug's effects, its mechanism of action, and its pharmacokinetics, while also trying to predict possible side effects when it is eventually used in humans. An equally critical component is safety and toxicity testing. First comes acute or single-dose toxicity, where very high doses are given to determine how toxic a drug can be and to establish an LD50, the lethal dose at which half of test animals die. Then come repeated dose toxicity tests, which look at subacute and chronic effects over weeks or months of administration. Beyond this, special forms of toxicity must be evaluated. Reproductive and developmental toxicity tests examine how the drug affects fertility, implantation, pregnancy, and fetal development. Researchers also assess dependence potential, meaning whether the drug can cause physical or psychological addiction. Antigenicity is studied as well, whether the drug itself can act as an antigen and trigger allergic reactions. Local toxicity is considered when the drug may damage a particular tissue or organ. For example, a compound may be hepatotoxic to the liver or nephrotoxic to the kidney. Finally, mutagenicity and carcinogenicity are tested to see if the drug can alter DNA, cause genetic mutations, or contribute to cancer development. Only after these animal studies show acceptable safety can human testing begin, and this takes the form of clinical trials. Clinical trials are divided into distinct phases. Phase 1 trials are the very first step in humans. They are usually carried out in a small number of healthy male volunteers. The main purpose is to confirm safety and to study pharmacokinetics, how the drug is absorbed, distributed, metabolized, and excreted. The data here provide the foundation for dose setting. Phase 2 trials shift to patients who actually have the disease being targeted. These trials are still relatively small, often divided into early and later parts. The aim is to observe both efficacy and safety in real patients, while determining the most appropriate dosage and method of administration. Phase 3 trials are much larger, involving many more patients across multiple sites. Here, the drug's effectiveness and safety are compared against existing treatments or placebo controls. Often, these are conducted as double-blind trials, where neither the doctor nor the patient knows who is receiving the test drug and who is receiving a comparator. This design eliminates bias and allows for fair, objective evaluation. When the trial ends, the coding is broken, and the results are analyzed statistically to determine whether the drug truly works and is safe enough for approval. Approval is not the end of the process. Once the drug enters the market, it is used by a much wider and more diverse population, including groups not usually included in clinical trials: children, the elderly, patients with liver or kidney disease, and even pregnant women in some cases. The drug may also be combined with many other medications. For this reason, post-marketing surveillance, also called Phase 4 studies, is essential. Here, adverse events are continuously reported, drugs are re-examined if concerns arise, and sometimes they are even withdrawn from the market. In summary, clinical evaluation moves step by step from small, early safety trials in healthy volunteers through larger patient studies to real-world monitoring after release. Of all these stages, Phase 3 trials carry the most weight in determining whether a new medicine will ultimately be judged both effective and safe.